So I'm Andrew Armstrong, professor of medicine at Duke, and I'm here presenting poster board H4, which is the clinical impact of bone scan flare or bone scan pseudoprogression in men with metastatic castration-resistant prostate cancer. In this study, we had access to two large phase 3 studies of enzalutamide, the PREVAIL and the AFFIRM study, all castration-resistant men. And we asked the question, does a new bone scan lesion at the first or second assessment in a patient who's otherwise responding to therapy have any clinical consequences? And in this study, we defined bone scan pseudoprogression as new bone lesions that are not confirmed with subsequent bone scan lesions. The patient's otherwise got a PSA that's going down, soft tumors that are shrinking. This is a true bone scan flare. In this study, as you can see here in the PREVAIL study, there was no clinical consequence to a new bone scan lesion that's unconfirmed, illustrating the importance of prostate cancer working group 2 and 3 at defining bone scan progression, that this has no clinical consequence, that you should treat through this and look at the patient and decide that they're actually responding. The counterpoint to that is in the AFFIRM study, patients with bone scan pseudoprogression actually have a worse survival and progression-free survival, illustrating that we need better functional imaging of these bone scan flares. The bone scan is not imaging the tumor directly, that in the more refractory setting, this heterogeneous tumor population may actually be indicating true progression, that these patients may have a worse outcome by treating through new bone scan lesions. And I highlight the importance of novel functional imaging to help clarify what's going on in the bone scan. Thank you very much.